My name is Jane Erb. I am a psychiatrist here at the Brigham and Women's Hospital and also an assistant professor of psychiatry here at Harvard Medical School. I've been practicing psychiatry since I completed my training in 1989 at UCLA. Have been doing primarily work with adults in an outpatient setting. Most of the focus has been on treating individuals with mood and anxiety disorders. Though I, over the last few years, have been increasingly involved in the more progressive collaborative care programming to help our primary care doctors to take better care of individuals with mood and anxiety disorders within the primary care setting. So my position here is as medical director of our depression center here at the Brigham, and I also work with the South Huntington Advanced Primary Care Associates, which is the patient-centered medical home. So much of it depends on the timing and other symptoms that are going on at the time. So for example, it's not unusual for average person to, in the context of period of poor sleep or increased stress, to become irritable. It's not unusual for an individual when they're feeling discouraged to shop as a means of kind of feeling better for a bit. So those behaviors don't in and of themselves suggest that an individual is bipolar. Rather, the key is the association of those behaviors with a reduced need for sleep, a sense of heightened energy and speed, often associated with observable rapid rate of speech and behaviors that are clearly leading to adverse consequences in that individual's life. So it's the context and the other parts of what's going on that are really critical to establishing the diagnosis. And even then, it can be very difficult to know for sure if somebody has bipolar disorder when the symptoms are mild or early in the course of the illness. An individual with bipolar disorder often starts with just episodes of depression, and you don't see the mania until their 20s or 30s. And so finding out more about family history and some of the subtleties of how the depression presented and when and how early in that individual's life can help us understand what an individual's risks are for developing full-out bipolar disorder.
The first time I was diagnosed, I said no. I said I didn't think I had that.
I was diagnosed when I was 15. My first diagnosis was bipolar manic only.
Yeah, and the depression came first and was really obvious, and then I was definitely manic during my 20s, and I wasn't actually diagnosed until, I was almost 50 as bipolar.
Well, I was diagnosed with depression, and I had a suicide attempt. And I remember that's the first time I saw a psychiatrist was right after that.
And the doctor had put me on Valium to try to control the spasming and the headaches, and it slowly stopped. It was over midsummer, and it slowly, I stopped taking the Valium, and I guess if you're prone to bipolar disorder, you can get something called paradoxical psychosis.
Bipolar disorder is sort of a spectrum of illnesses which are characterized by extremes of mood. So in the manic phase, typically an individual feels either intensely elated on top of the world or is intensely irritable in association with this amount of energy that is just experienced as all-consuming and so intense that they feel they don't need sleep, tend to get very little sleep, are ultra productive, able to accomplish far more within a set period of time than usual, tend to be much more outgoing, extroverted, social at those times.
Yeah, I'm aware that I've had times of extreme euphoria where I've become a lot more outgoing than I normally am, where I have slept less, where I had been creative, and maybe during my manias I made more connections than I normally would have, if you want to call them manias. I have had times when the colors have seemed brighter, when I would be walking around, or when I would go out with date more people, all those things, everything, So yeah, I've had times of, joyous times that are probably an extreme mood state.
Back in days when individuals we didn't have the treatment for mania, it was not unusual for someone to ultimately die from dehydration or malnourishment or have a stroke or heart attack because they were so physiologically stressed from the energy, the lack of sleep, the not eating, the forgetting to have fluids, etc. When the mania starts to hit extremes, the individual starts to engage in increasingly inappropriate social behaviors, often spending money they don't have, or disrobing publicly, or saying things that they wouldn't ordinarily say. Individual feels unusually creative and intelligent, and sometimes develops delusions that they are above the ordinary mortal and have powers that most humans don't possess.
It was almost like it was somebody else.
Walking into a car dealership and saying, I want that car, not test driving, and just signing my name and taking it home.
I had great difficulty with relationships, with not just deep friendships, but just ordinary type of friendships.
Well, I got stopped by the same cop twice downtown on the same night. The first time he yelled at me, and the second time I figured I'm gonna get arrested.
Just spending money like it was water. Spent 40 grand in 2 weeks, cash.
But for me, one of the symptoms of depression and mania is that it kind of pulls me back from people. So even if I'm physically present, I'm not really present.
It was sort of like the party in my head wouldn't stop. And I'm like living on carbohydrates and caffeine and ideas.
I would over tip at restaurants on the way out, $250. I bought a shirt at an Army Navy store that was $10. I gave the kid $100 and walked out.
And I'm like, but I've never been manic. And he pointed out my sexual behavior. And I had told him a bunch of things that I'd done. And
I couldn't stop doing stuff that seemed like a good idea, even if it turned out to be a really bad idea.
Did some crazy stuff with my car, and I guess I did a burnout in the showroom of a dealership.
And he's like, how many men would you say you slept with last month? And I'm like, 100? And he said, even allowing for cultural differences, that's pretty extreme.
To be manic and think I'm having a good time until the consequences happen. And they do. There were the consequences. I could have been arrested.
I got arrested on the beach for, things I wouldn't normally do.
Sometimes manic individuals are just really irritable and don't let you finish a thought and are jumping in and just talking over and can be extraordinarily sensitive to any perceived slight and So if you see that state in combination with that kind of productive energy, goal-directed behavior, and seemingly being able to feel fine without sleep, then that may well be a mania. At the other end, the depressions can be extraordinarily deep and seemingly relentless, associated often with no energy, inability to even move at times, where just the thought of getting out of bed in the morning feels completely overwhelming. The individual often feels hopeless, without a future, without meaning in life, sometimes feels as though their presence in this world is really just a burden to others, to nature, etc., and can become extraordinarily focused on wishing he or she weren't alive, and as the suicidal thoughts intensify, sometimes begin to plot how they will end their lives. But there are other forms where it's sort of mixed with a lot of agitation and sometimes an inability to sleep, but certainly not feeling rested, feeling the consequences, in other words, of not having sufficient sleep. So it's sort of on a spectrum. Less frequently does an individual become psychotically manic. But the majority of individuals with bipolar disorder actually have much milder versions of that, where they can present much like you or I publicly. And it's only once you drill down and start to hear more about the degree to which they're productive and not sleeping, and how it's in more subtle ways impacting their relationships and finances and so on, that you start to appreciate the mania that's occurring. Individuals with bipolar disorder, we see all gradations. The most extremes, it's probably about 1% of the population. Depending upon where one draws the line with those extremes, you can see variations on that within the bipolar spectrum in up to another 10% or so of our population.
I wrote something actually when I was 19. It was called The Well of Depression. That I was stuck in a well and it was dark all around, and it was hard to get out. I wasn't seeing any kind of therapist or doctor for it, but it was my English teacher in high school that asked me to write about it, because she could kind of tell that I was depressed. And it wasn't until much later that I started to see therapists for the depression. Well, I think probably the major symptom that I have is I would just cry all the time. I would, just for no reason, I'd start crying. I'd be on the subway, I'd be crying. I'd be at work, I would start crying. And really, since I've been on the antidepressants, that doesn't happen to me anymore.
The really evil part of mania, I found out, is that, at the beginning it just seems like optimism. It's fun. There's a lot of people who miss the mania. I sort of do, but I have other things that I'm interested in, like doing artwork. That's still, good, clean fun. It's a high, and the consequences are nothing like drugs or mania. I mean, illicit drugs. But at the end, the mania was terrible because I couldn't stop. I was physically absolutely exhausted. My body was felt like it had a dull electric current going through it, and I was too weak to stand up.
And if there's one thing that I want you to understand is depression is pure pain. And it's psychological pain, it's a hopelessness, but it's also physical. There's something in there all the time. And what it does is it traps you inside yourself. I think one of the worst things about depression is that you cannot come out, you cannot empathize with another human being. You're only stuck in your own pain.
treatments that are approved depends a little bit on which state of the disorder you are trying to treat. And so in the context of a manic episode, we have lithium and Depakote or valproate. We also have our newer generation of antipsychotic class medicines, all of which are established and approved by the FDA for treatment of bipolar mania. And so that would include risperidone, quetiapine, olanzapine, ziprasidone, aripiprazole, and more recently, lorazepam or Latuda has been approved.
Not all the medications work. No one's on the same medication and no one's on the same amount. They're always different.
Over here at the evaluation unit, they gave me Depakote to bring me down. It works pretty quick and was effective, except I was really sedated. And then there was a long period, few months before I could get a psychopharmacologist. So I was really sedated on Depakote for 3 months.
Typically one would start in the context of a severe mania with either lithium or Depakote, and oftentimes if the symptoms are severe, it would be paired with an antipsychotic class medicine that also has anti-manic effects. And then it's simplified as the mania remits. Key to really get the person sleeping again, because that's the sort of tipping point for when you start to see the symptoms remitting.
Well, I've been on old tricyclics. It's called desipramine and imipramine, which are older ones. And most recently, they put me on Wellbutrin, which is a newer antidepressant. It helps with my depression, helps with my mood.
At the other end, in the case of an acute bipolar depression, approved now are Seroquel, quetiapine, as well as Symbyax, which is a combination of Prozac and olanzapine or Zyprexa. It got approval simply because the company conducted sufficient studies and wanted to get the labeling for that, though I must say in clinical practice we don't typically go with that first line, but rather we will use quetiapine or lamotrigine, which while not officially approved for bipolar depression, has been found in clinical practice to be very helpful for many individuals as such.
See, the effect with Prozac was very obvious. And the effect of some other things is just like negative, like you have a headache or a bad taste, or you got to piss all the time, or you name it, and you wait for a positive effect and it doesn't happen.
Even when they do work, sometimes they fizzle out. And at one point, later on, the MAOI stopped working and I started getting depressed again.
Then we look at what seems to have the data that supports maintenance, preventing a return to either mania or depression. And so much depends at that point on what the individual seems to experience the most. If depression is the predominant state that keeps getting them into trouble, then we would probably lean harder on using something like lamotrigine, which has very well established efficacy in preventing a return to depression, and the antidepressant efficacy as well. So, and then lithium also is a go-to frequently because it really does seem to help prevent return to those states. And it also seems to have very strong capacity to help to reduce the risk of suicide.
Just really keeps me from being, everything being negative and dark. And
Depakote was very helpful, but over a longer period, like months, I was just dumb. I was sedated.
It took about 2 years to find the right combination, but when I did, again, I felt like my old self. I felt 100% better. I wanted to be 100% better, and I always pushed for that because I knew it was possible.
He got through to me by reasoning. He said, look, you've tried everything else that we use, you haven't tried lithium. I understand your reservations and why you don't want it, but nothing else has been helped. And he said, and I know you could be doing better than you are. They call it a mood stabilizer. I found lithium to be a mind stabilizer or a mind restorer.
Extreme cases would be, I guess, marked by individuals who presented with years of struggling to get out of highly recurrent depressions, and finally, the satisfying part being that we finally are able to get that under control.
Well, my last accomplishment was through the Transformation Center. I became a peer support specialist. So I went through classes and talked about my recovery, and I passed a test and I got a certificate, which enables me to get a job helping other people. And actually I volunteer here at the Cole Resource Center and help people that way.
If you hear a tear where you usually wouldn't hear a tear, pick up on those hints. Delve into those, because those could be soul-saving and thus life-saving for all of us.
So, and since being on medication, I don't get real extremes. I get, dips, but not the real extremes. Although I had my first euphoric manic episode since I was on an antidepressant that pushed me into one. So I don't know where that came from, but it was great. It lasted like half an hour, and then it was gone. I got depressed because it was leaving.
And once it started to take effect, it's been uphill from here. I've had my days, but for the most part, it's really, really been good to be medicated and working on myself and being able not having to self-medicate with alcohol, and it's been good diagnosis actually. Sad, as hard as it sounds, people think it would be. It's a bad diagnosis, but it's better than the struggle of living life undiagnosed.
You learn to endure a lot of stuff when you've got a long-term psychiatric situation. If you fight it, it'll just take a lot out of you.
Because I wake up every day not depressed, I am happy. And there's nothing that the world can throw at me that's going to take that away. And so as I know my life has been a little smaller than I thought it was going to be. I know I'm not as wealthy as I had hoped I was going to be. I do not have all the things that I wanted at this time in my life, but it doesn't matter. Every day I wake up, I'm happy, and I'm happy because I'm not depressed.